So RA patients have an increased risk of having cardiovascular events, so that includes heart attacks, strokes, having sudden cardiac death. It's probably increased at least 50% more than someone who doesn't have rheumatoid arthritis. And it's driven by the fact that rheumatoid arthritis patients have more atherosclerosis, so hardening of the arteries in their heart and in other areas of the body.
To what extent does the background inflammation in RA contribute to this whole picture, do you think?
It seems to contribute a lot, and particularly in people who have a lot of what we consider traditional cardiovascular risk factors. So if you have diabetes, smoking, high blood pressure, elevated lipids in your blood, if you have a combination of those plus inflammation, it makes that risk even higher.
When your patient with rheumatoid arthritis is sitting in your office and you have a limited time and a visit, what are the important things you need to make sure are being done, and what do you talk to your patient about with cardiovascular risk?
So we think about it in two ways. Number one, we want to reduce their overall level of inflammation by controlling their joint disease and getting the inflammation out of their joints, and that's accomplished with medications that are designed to immunomodulate their immune system. But the other side of the coin is to control their overall cardiovascular risk factors. That includes blood pressure, it includes diabetes management, getting them to stop smoking, getting them to exercise, healthy diet, and also to treat their LDL and total cholesterol with medications potentially if those other interventions are not successful.
Do you need to do anything different in terms of treating these patients and how you look at the lipid guidelines and taking care of patients with RA?
Well, there's no data-driven clinical guideline for that yet. So in terms of the best practical management, probably just doing what the guidelines say for the general population is appropriate for RA patients. And there's definitely a lot of data that suggests that as rheumatologists, we're not doing a very good job of screening and treating for lipids and cardiovascular risk.
What about the patient who comes back with a very low LDL and low total cholesterol and has RA? Can you just say they're in the clear and you don't have to worry about it? Or what do you think about that patient?
Well, we don't have the solid answer to that question yet, but there has been some recent data that suggests that RA patients with extremely low lipids who are not being treated with a lipid controlling medication, that those patients may actually be at heightened risk for having more atherosclerosis and also having atherosclerotic events. So we can't ignore those patients and assume that they don't have atherosclerosis when we see those very, very low levels of lipids. And it's tied to inflammation potentially, and it can be treated with statins potentially as well. Even if they have low lipids, there's a potential that you could improve their cardiovascular risk by giving them a statin medication.
And so you would march them through the algorithm of the guidelines as you would another patient regardless of their LDL?
Well, you probably would not see that the guidelines would estimate that their risk would be very high in that case, because having high lipids goes into the risk algorithm, but having low lipids does not. So in that respect, those patients may be appropriate for some sort of secondary screening for cardiovascular disease. In particular, maybe doing an imaging study of their heart. One way is to do a cardiac CT scan, which can pick up the amount of calcium in the coronary arteries. And if they have calcium there, they might have atherosclerosis there, and that might be a target for treatment in those patients. You could also consider doing an ultrasound of the carotid arteries, which can also pick up plaque and other measures of atherosclerosis.